We are live, we can start.
Yeah. Hello everyone. I welcome all of you to this webinar arranged by Pune Sinhagad Road Doctor Association. Rainy days gives us relief from our busy schedule and help us breathe again. So while enjoying this delightful weather, let us all join this CME delivered by very well-renowned speaker Dr. Vidya Rokde ma'am, Dr. Ramesh Bhange sir, Dr. Yashovardhan Bhange sir. We are all looking forward to learn most from this lecture. Now, I would request respected Pune Sinhagad Road Doctor Association President, Dr. Kamini Hinge ma'am, to say a few words. Over to Dr. Kamini Hinge ma'am.
Thank you, Dr. Vidyulata. Good evening and welcome all doctors. करोनाची दुसरी लाट आता पूर्णपणे ओसरली आहे. सगळ्यांनी मास्क मधूनच थोडा मोकळा श्वास घ्यायला सुरुवात केलेली आहे. परंतु ज्यांनी करोनाला फेस केलंय असे बरेच पेशंट आता प्रतिकार शक्ती कमी झाल्यामुळे एका भयंकर आजाराला तोंड देत आहे, ते म्हणजे म्युकरमायकोसिस. या आजारामुळे पेशंटला काही वेळा कायमस्वरूपी अपंगत्व येत आहे. काहींनी आपला एखादा डोळा, काहींनी श्वास घेण्याची आपली जी वाच क्षमता आहे ती गमावलेली आहे. तर या आजाराचं वेळीच निदान होणं आणि त्याला योग्य उपचार मिळणं हे अतिशय गरजेचं आहे. तर ते मार्गदर्शन करण्यासाठी आज आपल्याकडे डॉक्टर रमेश भांगे सर, डॉक्टर विद्या रोकडे मॅडम आणि डॉक्टर यश भांगे हे आलेले आहेत आणि आपण त्यांचं मार्गदर्शन आज घेणार आहोत. आता यांना आपले जे मॉडरेटर आहेत डॉक्टर प्रसाद सोनी सर, तर हे आपले जे लेक्चरर आहेत त्यांचं इंट्रोडक्शन करून देतील. ओव्हर टू डॉक्टर प्रसाद सोनी.
I think Vidyulata Doshi's madam is going to introduce the program.
Yes. Now moving forward, let us introduce today's moderator, Dr. Prasad Soni sir. यांना कोण ओळखत नाही पुणे सिंहगड रोड डॉक्टर असोसिएशन मध्ये असं नाहीच आहे. डॉक्टर प्रसाद सोनी सर डन BMS from Pune, PG DGM Geriatric Medicine, practicing at Soni's Clinic, Dahiri and Vadgaon since 20 years. He is a trustee and medical director of Spandan Care Center, a center for old bedridden people. He is a past president of Pune Sinhagad Road Doctor Association. He is a past committee member of General Practitioner Association. He is a past organizing chairman of GPMed 2007. Now I will introducing first speaker, Dr. Vidya Rokde ma'am, who will be discussing overview of mucormycosis with us. Dr. Vidya Rokde ma'am. She has done MBBS and MS ENT from BJ Medical Pune. She worked in the NHS and UK for 5 years. She is working as a professor at Srimati Kashibai Navle College at Nare. She is working as assistant professor in BJ Medical College. She is founder president of Anmol Charitable Foundation, which is working for betterment of autistic children. Now I call upon Dr. Prasad Soni sir to introduce our second speaker. Over to Prasad Soni sir. Sir, unmute yourself, please.
Thank you, Vidyulata Doshi madam, for your kind words. And it's really my privilege to introduce to Dr. Bhange sir, Ramesh Bhange sir, and young and dynamic Yash is going to guide us on mucormycosis and dental aspect. Let me introduce first Yashovardhan Bhange. Recently, he has completed his BDS from the Bharati Vidyapit Dental College, Pune, and assisted in mucormycosis surgical interventions in few of the cases. So he is having a very handy experience regarding this mucormycosis cases. So it will be interesting to listen to Yashovardhan. So welcome Yashovardhan. Our last speaker is Dr. Ramesh Bhange sir. He has completed his MBBS and MS ophthalmology from the Vijay Medical College, Pune, and he is a consulting eye surgeon and oculoplasty surgeon. He has worked in burns and plasty department of Vijay Medical College for 3 years and performed many plastic surgeries like orbit, oculoplasty, and the squint surgeries. I think many of us, even I was not knowing this aspect of the sir, that sir has worked in the plastic department of the Vijay Medical College. So great. He is a consultant at the Pune Hospital in the Research Center and Zadav Eye Foundation, Vadgav Sheri. He is the honorary eye surgeon at the Netra Seva Pratishthan, Pune, and said Tarachandra Ramnath Hospital, Rastapet, Pune. His achievements are: he is a past president of the Rotary Club of Pune, Lokman. He was past president of the Rotary Club of Pune, Lokmanya Nagar, and one more. It's really a proud moment for all of us as he's from the Sinhagad Road, and Bhange Madam was the president of the Sinhagad Road. That sir is a Limca book record holder, and sir, along with his team, performed maximum number of squint surgeries, that is 156 surgeries in 24 hours at the Netra Seva Pratishthan at Sani Guruji Hospital at Hadapsar in 2009 and 10. And believe me that this whatever I read out about the Bhange sir, this is the 20% of his total biodata. And when I saw his biodata, I actually got I think it would have taken more than 15 minutes to read out that biodata. So thank you, Bhange madam, who helped me out, and she concised that biodata, and it's really within 1 minute I finished it. So welcome Bhange sir, welcome Yashovardhan, and now hand over charge to Rokode madam to begin her speech. So all over to you, Rokode madam, please.
I'll just see that I'll share the screen first. Hello.
Yes, it's visible, ma'am.
Dr. Rokade, please unmute yourself.
Hello, can you hear me now?
Yes.
Yes, we can hear you now.
Yes.
Please go on.
Okay, thank you. Good evening, everybody. And at the outset, I would like to thank the organizers for giving me this opportunity to speak on a current challenging situation due to mucormycosis. During the second wave of COVID-19 epidemic, we have seen this sudden rise in the number of cases of mucormycosis. Even the media was full of this black fungus everywhere. And everybody is aware that mucormycosis is a deadly infection, and everybody is aware because of the media. Even the common man is aware of this black fungus nowadays. So now it is like a situation like a COVID epidemic, and there is an epidemic of the mucormycosis. So today my topic is the mucormycosis, a post-COVID perspective. So I'll start with my topic. It's mucormycosis. We'll discuss first in general, and then I'll go with the specific with the rhino-orbital and cerebral mucormycosis. Mucormycosis is also called as a zygomycosis. It is a saprophytic fungus and it is a saprophytic fungal infection, which is aggressive, opportunistic, and devastating fungal infection with a high mortality rate. It belongs to the zygomycetes class. The species is Mucor, Rhizopus, Rhizomucor, and Absidium. What we see is a commonly is the Rhizopus and the Mucor. This and the rest of them, they are occasionally along with it. It is a rapidly progressive fungal disorder, and in delay in identification and management can lead to the high mortality and the high morbidity. Here is a structure of the mucor fungus. We can see is the hyphae here and the sporangia and sporangios. So if we take a swab from the nose, nasal swab and nasal secretions, and if we want to diagnose it as a fungus, then we can look it under the microscope with the KOH mount. The picture will be like this. So we can see the hyphae here and the spores. So that is a diagnostic of the fungal infection because of the mucor. So how does it spread? The fungus is ubiquitous in nature. It is already existing in the nature. It is present there in the soil. It is usually present in the decaying organic matter. So even the fruits, decaying fruits and bread like that. So it can spread like getting entry into the human being by inhalation, by the nasal route. So it can get via the nose and spread along the respiratory tract, nose, paranasal sinuses, and adjacent structures. It can spread directly through the cut or open wound over the skin. It can be swallowed as ingested and leads to the gastrointestinal manifestations. This fungus, is characteristic of this fungus is it is angioinvasive, and which leads to the occlusion of the blood vessel. And because of that, there is a necrosis of the tissue. So once the blood supply is hampered, the tissue becomes dead, and that necrotic tissue looks black, and that black discoloration is given it's a name which is a actually misnomer, which is a black fungus. So what are the predisposing factors for the mucormycosis in general? So it is usually seen in the patients with those they are immunocompromised, those they are having the uncontrolled diabetes mellitus, those they are on the broad spectrum antibiotic for a longer term, those they are underwent the organ transplant surgeries, the suffering from the malignancies. So overall global prevalence of the mucormycosis is very rare. It's a 0.005 to 1.57 per million. But it is high incidence is noted in India. So, and at present, we are loaded with the cases of the mucormycosis. The last few months, it started at the end of the April, and the May was the full of the mucormycosis. So yet the data needs to come up, and then you'll know the ground reality of the incidence of the mucormycosis in the post-COVID era. So we'll have to wait for exact data. Even in our setup, in our institute, in the last month, we have seen 35 cases, and yet the new cases are coming every day. And we are operating them on everyday basis, depending on the prioritizing the cases, depending on their symptoms. So we categorize them in the high-risk patients in the post-COVID infection. So those they are having the uncontrolled diabetes, those they required the oxygen therapy for the longer duration, inappropriate use of steroids, those they were on the high doses of steroids, and the prolonged periods for the usage of the steroid, prolonged stay in the ICU, people under those requiring the ventilatory support. So these are the patients, those they are in the ICU, and along with the diabetes mellitus and requiring the high doses of steroids, they are in the high risk group. And the rest of the things are we need to take precautions of using the sterilized instruments or the sterilized gadgets, even the linen mask. We need to have a clean linen, so that to prevent this prevent the occurrence of the mucormycosis. So there are another thing is why in COVID-19 patients the mucormycosis is so rampant. Primary reason that appears to be facilitating mucoral spores to germinate in people with COVID-19 is an ideal environment of low oxygen. So that is a good environment for the fungus to grow in. The another one is a high glucose levels. The diabetic patients and even the steroid induced hyperglycemia, maybe it's a temporary, but if it is not controlled and not addressed, then that is also another indication for good environment for the mucor to grow in. Then a high iron levels, increased ferritins level in the blood, the acidic medium, the metabolic acidosis, diabetic ketoacidosis. And as we are all know that these are the immunocompromised patients, their immunity is so low. So decreased phagocytic activity of white blood cell count, all these counts and gives a good medium for the fungus to grow in. So these mucormycosis is categorized depending on the organs involved. So one of them is a rhino-orbitocerebral, which is the commonest one. And nowadays we are seeing the more cases of this rhino-orbitocerebral mucormycosis, which involves the nodes, paranasal sinuses, orbit, and the cerebral region. And the others categories are pulmonary mucormycosis, cutaneous mucormycosis, gastrointestinal mucormycosis, bone and joint infection, even the disseminated mucormycosis. So basically, in the rest of my presentation, I'll be mainly addressing the rhino-orbitocerebral mucormycosis. So before that, I would like to give a brief description of the anatomy of the paranasal sinuses and the nodes, because it's very important to understand how it spreads and how it is important to diagnose it early so as to give a better cure to the patient. If we look at the anatomical diagram, we can see the nodes and the paranasal sinuses. These are the anterior paranasal sinuses, anterior group of the paranasal sinuses, maxillary sinus, ethmoid group of sinuses, frontal sinus. This is a nasal septum which divides the nose into two halves. This is the inferior turbinate, middle turbinate. The posterior group of the sinus is the sphenoid sinus, which is behind the nose. And we can see here is a nasopharynx and going into the leading towards the pharynx. So if we look at this, the frontal sinus and the sphenoid sinus, see the close proximity to the brain. Here, the orbit, the eyeball is also very nearby. So this whole complex, if we understand the anatomical presentation of this complex, that's how it becomes very important. Important to know this. It will help us to diagnose it early, and the importance of knowing why to diagnose it so early. This is a bony structure. If we see this orbit is just separated from the ethmoidal sinuses by a thin bone which is called lamina propria. Once it is destroyed, the disease, any disease can easily go into the orbit. Here, this is a roof of the maxillary sinus. Even this is breached, and here is the infraorbital foramen. So infraorbital nerve is lying there. Once it is affected, neuritis, the patient will have this facial numbness. That is the typical characteristic, one of the sign and symptom of mucormycosis. Here, if we see, this is also vital organ. The orbit is so nearby. The maxillary sinus in this diagram, if you see the maxillary sinus, the floor is related to the root of the teeth, the molars. So that is also how it affecting the jaw. Once it goes posteriorly, the direct spread from the pterygomaxillary fissure into the pterygopalatine fossa, and this very small area which leads to the infratemporal fossa, from where it can directly connect it to the brain. Here at the roof of the nose, what we can see is a cribriform plate, and from here also it's easy to go into the brain. So that is the one of the root way of the spread, that is a direct spread or by destruction of the bony landmarks, and the another one is a hematogenous spread. So hematogenous spread also, it's quickly goes and spreads to the orbit, it quickly goes and spread to the brain. So if we can diagnose it early and treat it early, we can prevent the spread to the orbit and the brain. So that is how it is anatomically also this complex is very important to know. So how these patients will present to us? The clinical presentation of the patients. So they can present to the ENT surgeons to us as like a presentation like a sinusitis patient. This maxillary affection can present to the dentist. They will have a toothache, loosening of the maxillary teeth, the upper jaw teeth. So usually, because it is close to the maxilla, the maxillary teeth will be affected. Jaw involvement, palatal involvement. So palate, this can be eye symptoms. If they are having the eye symptoms, they can present to the ophthalmologist directly. Altered sensorium because of the cerebral affection or the brain affection, they neurologist, and the general, they will have all of them, most of them, they will come with the headache, low grade fever, malaise, and lethargy. So depending on the severity of the symptoms and the affection of the organ, they can present to the ENT surgeon or ophthalmologist singularly. If usually these symptoms, they will start after the 5 to 7 days post-COVID infection. But what we have seen is that most of the patients, they were discharged after 7 day or 8 day, and after few days, means after 10th or 11th days, they are coming back in the OPD with the complaints of facial pain, or sometimes with the swelling of the eyes, pain and numbness over the face. So the commonest clinical presentation with the nasal symptoms are nasal blockage, blood-stained nasal discharge, facial pain, swelling over the face, or the numbness over the cheekbones, headache, swelling of the eyes, double vision, if it depends on the organ involved. So double vision, it's a diplopia, or sudden diminution of the vision. Toothache, loosening of the teeth, discomfort during chewing, lesions over the palate. So the other organs, if the other organs are involved, the pulmonary manifestations will be, that is a non-productive of progressive dyspnea, refractory fever, even though patient is on the antibiotics. So pleuritic chest pain. When there is a cutaneous or the soft tissue mucormycosis, then we will see the erythema or induration over the skin, black discharge at the site of trauma or puncture, muscle pain with a deeper involvement. If it is a gastrointestinal mucormycosis, the patient will most probably will present with the fever, bleeding per annus, mass-like lesions, and perforation of the gut. Mucormycosis at the bones and joints with the local pain and tenderness and cellulitis. And if there is an involvement of the brain, cerebral involvement will have a altered sensorium of the patient along with the rest of the, depending on the organs involved, the clinical presentation will depend on that. So once we know that we are suspected the patient is having a mucormycosis, with a thorough clinical examination of the patient is very important, and taking the detailed history of the patient. So at the current scenario, we know that these patients are post-COVID infection patients. So that history will be there. Then the history of diabetics, mellitus, diabetes, or along with the high risk other history of oxygen therapy and with the steroid treatment. So all this we need to take into consideration. But coming to the, once we are suspicious of mucormycosis, the most important thing is to diagnose the mucormycosis and then the management of the mucormycosis. By that time, the patient must have done all routine examination. But the most important thing is a blood sugar level, which is to know whether it is controlled or not. And depending on that, we need to have a glycemic control of the patient. Then the renal function test, they are utmost important. We need to know the serum creatinine levels, because the rest of the few things, even the CT scan and the contrast management, that time also we need the serum creatinine at the normal range. Then comes the tissue diagnosis and the radiological diagnosis. So radiology is very important at this point, the investigations, because we need to know the involvement of the tissues. So this radiological investigations will give us an idea about the extent of the disease, and the management of the disease will depend on the how far it is extended. So who is going to get involved into the management, that depends on the report of the CT scan and the MRI. So here there is a dilemma whether to go for the CT scan of the paranasal sinus is sufficient or not sufficient. But particularly the CT scan gives the bone erosion. So bony destruction will be known on the CT scan of the paranasal sinuses. But the MRI with the gadolinium enhancement, which is very important in mucormycosis, because that will give us an idea of the extent of the disease. Then comes the histological diagnosis or the biopsy. Even we can take initially we'll go for a diagnostic nasal endoscopy of the patient, which is a OPD procedure done under without any local anesthesia, or sometimes the patient is apprehensive, then we use a 10% xylocaine nasal spray to do the diagnostic nasal endoscopic examination. So during this, we can get the nasal swab. Secretions of the nasal swab are sent for the microscopic examination for KOH mount to know whether there is a fungal infection. If the nasal crust is present, then we'll take the nasal crust. And if nothing is, there are few cases we have seen that we found the nasal mucosa is almost normal looking. So first two samples, twice we have done the microscopic examination, sent it for the KOH mount, the nasal secretions. They were negative for the mucormycosis, but the patient had a facial numbness over the cheek and pain. So even the mucosal biopsy from the turbinates were sent for the histopathological examination. So this sample we need to send into the 10% formalin, but for the KOH mount and for the microscopic examination, the samples needs to be sent into the saline. So even the histopathological examination from the nasal mucosal biopsy was also negative. But the MRI, when the MRI was done, the patient came from the outside, outside with the CT scan and these reports, and all those they were negative. Then we did the MRI of that patient with the gadolinium scan, and then we found there is a extensive disease found into the periopalatine fossa. And So the sinuses and the nose was clear, but the disease was behind into the sphenoid sinus and the pterygopalatine fossa. So the clinical suspicions and the MRI is utmost of the very important to know the diagnosis and the extent of the disease. So this is the nasal endoscopic picture. So most of the time you can see that this is the inferior turbinate and the septum. The black crust, presence of the black crust. We need to remove the crust and the swab is taken from even the crust we can send, and the swab, nasal swab, we can take it from the secretions. The CT scan, this is just to give an idea. This is a normal looking all the sinuses, inferior turbinates, middle turbinates. These are the ethmoid sinuses. And you can see this is the lamina papricia, orbit, and the muscles of the orbit. Here on this CT scan, which shows the destruction of this lamina papricia, and there is an extension into the orbit. Even the muscles are inward. So this is a picture which shows a haziness in the sinuses as well as the destruction of the bone here. So that CT scan gives us an idea about the destruction of the bony landmarks, whether the bony bones are intact or not. And it is very important from the surgical point of view. The surgeon would definitely like to know the bony landmarks because it's very important to know the bony landmarks. This is a MRI scan of the MRI scan which shows a blackish discoloration of the inferior turbinate. So this is a black turbinate sign, which is, and here we can see the blackish discoloration is because it is a devoid of blood, and that's why it looks black. So that is the advantage of the MRI over the CT scan in the mucormycosis. It gives an extension. Here you can see it's going behind, and even in the pterygopalatine fossa there is an extension. So how to manage these patients? The medical management with the antifungal drugs, surgical management, depending on the involvement of the organ, it needs a multidisciplinary approach, which involves the ENT surgeons, ophthalmologists, and the dentist also. Adjuvant treatments like a hyperbaric oxygen, deferresirox, and treatment of comorbidities. And if the patient's hemoglobin is very low, then use of blood and the blood components are also very important while managing these patients. So surgical management is what we need to do is an aggressive surgical debridement of the devitalized tissue and the drainage of all these sinuses, those they are involved. So what we as a ENT surgeon, we do is a functional endoscopic sinus surgery. So endoscopic sinus surgery and removal of the disease from all the sinuses. Depending on the extent, we need to go till the anterior base skull. Sometimes the patient needs a maxillectomy also if the maxilla is involved and the posterior part is involved, and orbital decompression. So these are the few pictures I'd like to show you. This is an endoscopic surgery view, but if you look anteriorly, the turbinate septum looks normal, and this is a posterior extension. Once we remove this scab and everything, we found that the involvement because of the mucormycosis, which is a blackish discoloration. This is involving all this. You can see the bony sequestra and pus also behind it, involving the posterior part, even the sphenoid sinus. So the debridement is the key of this, so that we remove the dead tissue and so that the drugs can reach up to the normal tissue. So the medical management is in the first line of treatment is with the liposomal amphotericin B. It is given as a 5 milligram per kg per day, diluted in 200 cc of 5% dextrose over 2 to 3 hours of infusion. In the case of cerebral involvement, the dose is increased up to the 10 milligram per kg per day. The another drug is a amphotericin B deoxycholate, which is more nephrotoxic than the liposomal. So the preferred drug is liposomal. But if it is not available, then even now we are trying the amphotericin B. But nowadays this is also not available easily. This we used to use it to give lavage after the surgery. Then the oral antifungals is a step down treatment once we give a patient to the amphotericin B, posaconazole, isoconazole, and the itraconazole. The posaconazole, this is, and isoconazole we can give even in the form of infusion if amphotericin B is not available. And the orally, it's given a three doses are almost same, is 300 milligram twice a day on a day one, and thereafter once a day. And this isoconazole is a 200 milligram 3 times a day for 2 days, followed by once a day for 3 to 6 months. If all these are not available, then we can try this, the itraconazole 200 milligram 3 times a day for 3 to 6 weeks. And stop while giving this, we need to stop proton pump inhibitor, H2 blockers. This needs to be consumed along the food so as to stop the gastric irritation. And we need to monitor the LFTs weekly. Thank you.
Thank you very much, Rokade madam. We all know that this is a very extensive topic, so you really made it very short and conveyed the message. Thank you very much. Now I request the next speaker, Dr. Yashovardhan Bhange, to deliver the speech. Unmute yourself. Dr. Yash, please unmute yourself.
Thank you, Dr. Vidya Rokade. That was a very good presentation on the generalized aspect of mucormycosis and the diagnosis and treatment. First of all, I would like to thank the President, Dr. Kamini Hinge, and the Secretary, Dr. Vidyalata Doshi, and all the committee members for giving me this opportunity to present in this webinar. I will be speaking about the dental aspect of the disease mucormycosis and the diagnosis and the treatment. I will start the screen. Thank you. Is my screen visible to everyone?
Yes.
Yes.
Okay, I'll start now. So these are the clinical manifestations as Dr. Vidya showed us. These are the generalized manifestations, that is unilateral pain, unilateral headache, pain behind the eye, facial pain, eye swelling, proptosis, the visual disturbance, which can either be diplopia, that is double vision, or the swelling of the eye, the necrotic lesions, which will be seen on the hard palate and the nasal mucosa, nasal congestion, the black discharge running through the nose or the sinuses, the epistaxis, and systemic symptoms like fever. So as we all know, the oral cavity is a hub for millions of microorganisms, that is the oral flora and fauna, which are non-pathogenic. But when the person is in an immunocompromised state, for example, if he is suffering from diabetes mellitus, or he is HIV positive, or he is undergoing, or he has undergone a organ transplant, or if he's just recovered from a disease like COVID-19, which we all know right now. So then the oral cavity is prone to infections because of the fungi, the mucormycosis infection. The dental symptoms which the dentist can clearly see if the patient comes to their clinic are first of all are the mobile teeth, and the halitosis, that is foul odor from the mouth, dental pain, the palatal ulcerations, intraoral draining sinuses, which will be characterized by, in the oral cavity, the clinician will be able to view the discharge coming from the maxillary sinus, and there's one more thing which they can diagnose, which the patient will tell them, is nasal stuffiness, then nasal discharge, then erythema of the nasal mucosa, the discoloration of the nasal mucosa. It might be blackish blue or black in color. Then facial erythema, black discoloration of the skin. This on the slide, as you can see, is the swelling of the eye, proptosis. These are the necrotic lesions which you can diagnose. As ma'am mentioned, since the maxilla is more prone to the fungal infection as it lies close to the maxillary sinus, and it is most commonly seen in the maxillary teeth. This you can, the necrotic lesion which you can see over here, the blackish yellow form of lesion will be seen. It will be easily scrapable and the edges will be indurated, that is, they will be hard. And over here you can see the blackish discoloration of the nasal mucosa. So mobile teeth. Tooth mobility is the horizontal or vertical displacement of the tooth beyond its physiological boundaries. That is, it's the space where it is supposed to be. It will be moving. That is the medical term for a loose tooth. This is how it will appear in the oral cavity. Halitosis. So halitosis is a form of chronic bad breath. So this is the type of foul odor which will persist even after the patient has brushed his teeth, or so this is the type of odor which will be emitted from the patient throughout the day. It is not just something which will be there once he wakes up or once he has a meal. Then dental pain, that is a toothache or tooth pain which can be caused because of various reasons like tooth infection, decay, injury to the tooth, or loss of a tooth are the most common causes of a dental pain. And when a patient will come to you with a dental pain, and if you can see that the tooth is fine, so there is no presence of caries or any infection or any injury, and still the tooth is mobile and the patient has pain, this is a very good indicator of the fact that he can be susceptible to mucormycosis. The parietal ulcers, as we can see over here, they will be seen mostly in the maxillary area. This is the ulceration on the hard palate, as you all can observe. The gingiva will be swollen, and as the teeth will be mobile, the gingiva will also be swollen. There will be slight bleeding or or ulceration on the gingiva also. It is very easy to confuse these conditions as periodontitis, but early diagnosis of this and early tests and diagnostic procedures can remind us if this can help us in diagnosing if this is a mucormycosis case. The ulcerations of the tongue, as you all can see, it will be reddish. So as you all can see over here, the drainage from the dental sinus can be observed like this. So nasal congestion can be caused by anything that irritates or inflames the nasal tissues, such as cold, flu, or sinusitis. And if the patient presents to you with nasal congestion, along with all the other indicators in the oral cavity, then it is then you should definitely give him the heads up for other diagnostic procedures. The purulent nasal discharge, as you all can see from the nasal cavity. So normally the nasal mucosa is pink in color, but when the patient is suffering from mucormycosis, it will be discolored, that is, it will be black in color or brownish black. Erythema, as you all can see, is the discoloration of the skin, that is a reddish color. And it occurs because of increased blood flow in the superior capillaries. It can occur with any type of simple skin injury or something more serious like infection or inflammation. Fungal infections such as ringworm, tinea versicolor, and candida can also trigger a discoloration of the skin, and it is usually much more serious. That is, it will appear blackish in color. So key points for dentists are to note down the chief complaint and ask for the symptoms related to the oral cavity, whether if any symptoms about the sinuses, any history of discharge from the oral cavity, purulent discharge, or any history of visual impairment. Then taking the history of COVID-19 infection, if the patient, whether he was admitted or if he had gotten steroid therapy for the same, which will make him more susceptible to the fungal infection. Then checking the discharge file for markers like raised blood sugar levels. Then evaluating the patient's oral cavity for the red flags, which we all saw before. And then, sorry, okay. And one more thing is to avoid rushing into extraction for the mobile teeth in a COVID-19 recovered patient without the complete evaluation from the ENT surgeon. And as Dr. Vidya Rokkade ma'am said, it is a team effort. So any invasive procedure should be performed with the evaluation from the other doctors as well. And if the intraoral draining sinus is present, if the intraoral sinus is present, then the KOH mount sample should be sent for fungal culture. So the prevention for this will be, from the simplest point of view, it is to be maintain the highest personal and oral hygiene, wear face masks and face shields all the time, not to take steroid supplements or other sweet foods and avoid them, and watch over your blood sugar levels if you are suffering, if you are already in an immunocompromised state. Regular dental and physical checkup, monitoring blood sugar, your own blood sugar levels, and more importantly for diabetics after recovery from COVID-19. Then avoid activities involving close contact to soil and dust, as we know, because the bacteria is more commonly present in these sites. Then regularly cleaning your fridge and pantry and damp moist places around house, which can very well aid in the invasion of the bacteria into your microorganism into your oral cavity. Then the maintenance of oral hygiene and use of 2% povidone iodine gargles. So this will be prevention in a post COVID-19 patient. So the judicial at least 3 times a day, regular use of povidone iodine gargles, then steam inhalation to improve the sinus health, regular use of betadine nasal irrigational spray, then strict glycemic control, that is keeping close watch on your blood sugar levels. And one more important thing is to defer all the non-emergency invasive oral or dental procedure for at least 3 months after a COVID-19 infection. So if it is not an emergency procedure, then you should first take the consent of your physician, and all the other evaluation should be done before performing any invasive procedure in the oral cavity. And also important is to avoid all forms of smoking and smokeless tobacco like gutka, kenny, and betel nut chewing, and alcohol, as it has a synergistic effect in oral cavity, and it will definitely make it more susceptible to the infection. These are the betadine gargles and the nasal spray, which is available over the counter in the medical stores. So this is a brief outlook of the common symptoms and the precautions which you can take. Treatment, as we know that no specific treatment is available for mucormycosis, but it is a joint effort by all the ENT surgeon, the neurosurgeon, the oral maxillofacial surgeon, the pathologist, and it is mainly treated with antifungal drugs. And surgical treatment is done in wherein the aggressively all the debridement is done and the affected tissue is removed. And this is how it will be treated. Thank you.
Thank you, Dr. Yash. It's really a short but very informative talk. And thank you very much on the behalf of the Pune Senior Doctors Association.
Thank you.
Now we will move on to our third and the last speaker, Dr. Ramesh Bhange sir. Dr. Ramesh Bhange sir, please, you can begin your talk.
Good evening, everybody. It is high time. It's quite late. I and most of the topics, clinical things has been covered by Dr. Vidya Rokde, Dr. Yash Bhange. I would like to thank President Dr. Kamini Inge and the Secretary Vidyulata Doshi and the all committee members. I would like to make the talk interesting by cutting off the things which will avoid repetition. Yes. पुढे जात नाही.
Sir, your voice is not audible.
Just wait. Okay, already you know it is a opportunities devastating in infection caused by a fungus. The most important thing is that it grows in a environment which has got a high doses of glucose, and second thing is which has got a high iron content. Therefore, because of COVID-19, where there is a lot of hemolysis occurring, and which leads to increase in the serum ferritin levels, which makes it vulnerable for the mucormycosis. This has been covered. Now, generalized presentations. What as a practitioners, what we are supposed to look for? The thing is that it is not necessary that the patient should have a COVID infection or no. The patient, those are whether the patient is vaccinated or not, or the whether the patient has received both the vaccines or no. We have found the mucormycosis infections in the patient who has been vaccinated, who had COVID, or the patient those who didn't have COVID but they had low immunity. Therefore, what is important as a practitioners, is important is to look at the symptoms that are which will tell us regarding the early symptoms of the things. A continuous headache is one of the important thing. Second is the low grade fever is another thing. And nasal blockage is another important. In ocular manifestations, what is important is pain and redness around the eyes, watering of the eyes, failing of the periorbital and discoloration. Other is diplopia, diminution of vision, drooping of the eyelid, ophthalmoplegia, and facial swelling. Now I will go for the clinical things. Why we want to investigate mucormycosis and why we are trying to save the life. The thing is that mucormycosis, if you take the mortality rate, it is about more than 50 to 60%. And because of increase in mucor cases during the COVID pandemic, it has definitely made us to think about this disorder of the disease in a very definitive manner, so that we can plan the management of the mucormycosis according to the protocols. There are various guidelines that has come from All India Ophthalmological Association, government task force, which has made us to think of managing the mucormycosis in early stage so that we can make sure that the patient and the mortality has been decreased. For that thing, for mucormycosis, what is important for us is we have to do the staging of the mucormycosis so that we can locate the disease and do the proper approach for the staging of the disease, and we can start the treatment accordingly. This will change the management protocol in every cases. What is important for us is the anatomical progression. As Dr. Vidya has told us and Dr. Yash has told us that basically the infection starts either in the oral cavity or it starts in the paranasal sinuses, and it may bypass all these organs and entered into the bloodstream by vascular channels, where it has been found that we are getting embolization because of mucor. Now, what it has been done recently that the mucormycosis management has been classified or graded or staging has been done so that we can treat the mucormycosis where the minimal surgical intervention is done. Now, when we go for the stage 1, there is a involvement of the nasal mucosa. In stage 1, it may be limited to the middle turbinate. Second stage is involvement of the inferior turbinate or the ostium of the nasal lacrimal duct. Third, next is involvement of the nasal septum, and fourth is bilateral nasal mucosa. Why it is important that patient may not be symptomatic in all these stages, and the diagnosis and the medical management is possible during stage 1. In stage 2, where for rhinoorbital cerebral mucormycosis, involvement of the paranasal sinuses is very important. In stage 2, the A is only one sinus is involved. Stage 2 is two sinuses involved on the same side. 2C is bilateral two sinuses or palate or oral cavity, and 2D is bilateral paranasal sinuses involving the involvement of the zygoma and mandible. How do you assess such case? Basically, a diagnostic endoscopy is very important, and in contrast enhanced MRI must be done in all these patients rather than doing a CT scan in these patients. These images has been already shared by Dr. Vidya. Now stage 3 is involvement of the orbit, where as an ophthalmologist our role comes into picture, where why we are treating or why we are as an ophthalmologist are involved in the rigorous management of mucormycosis. The basic important thing that we should know that just behind the orbital margin, the orbit, there is a brain, and the anatomical important two things are there. That is superior orbital fissure and inferior orbital fissure, optic foramen are very close in proximity with the brain. Now, when we are doing the staging for whether to do a medical management in this patient or whether to do the surgical management in these patients, this grading is important. Now, in stage 3, where there is an involvement of the orbit, the nasal lacrimal duct is involved in 3A, 3B, the diffuse orbital involvement, it is more than 2 quadrants. Stage 3 is central retinal artery occlusion or the ophthalmic artery occlusion or bilateral involvement. Now, why this is important is that when we want to do this staging where we may not do a surgical intervention in all these patients. Now, these are some of the clinical pictures. That is just a lead edema. And this could be a unilateral ptosis. This is severe lead edema with progressive change in color. Now, why we are interested in finding out or doing the MRI of the paranasal sinuses and the orbit. The earliest sign that has been noted is that the tissue ischemia, which makes the in MRI, the sign of ischemia appears. Therefore, all the muscles are appear as a hypotense. Therefore, that is the earliest sign in MRI. This is for the ocular motility. Therefore, when you see a patient in OPD, if the patient may not complain of diplopia because he must have, because of psychological trauma, the patient usually think that this is a post sequelae of COVID, and they may not come to know that their orbital involvement is occurring. Therefore, what is important is restriction of the movement. Therefore, you have in OPD, you are supposed to see whether the eyeball movements in each eye and binocular movements are normal or not. This is the rapid progression of the ptosis to proptosis and chemosis. We have seen the patients landing up into ptosis, proptosis, and chemosis within a period of 2 hours. The infection spreads that fast. Sudden onset ptosis with ophthalmoplegia is the key thing for the early diagnosis of mucormycosis. Now, sudden onset of central retinal artery occlusion can occur because of mucor emboli or secondary compression of the optic nerve. This is how clinically the proptosis and chemosis occurs. Now, stage 4, where there is involvement of the CNS. In stage 4, there is a 4A, there is a focal or partial involvement of the cavernous sinus involving both the cribriform plate. Stage 4B is diffuse cavernous sinus involvement, 4C involvement beyond cavernous sinus, and 4D is multifocal or diffuse CNS involvement. Now, when to investigate the patient? This is one of the important criteria that has been suggested by ICMR and the All India Ophthalmology Society, where we make the score as we make the HRCT score, where we look for the involvement of the lungs and everything. Same thing is applied here. If there are, depending upon the signs and symptoms, we do the scoring. If there is a facial pain plus paresthesia, the score is 0.5. If there is a headache, 0.5. If there is a nasal stiffness, 0.5. If there is an eyelid or facial edema, it is 0.5. The other thing is recent recovery from COVID, use of steroids in COVID, sudden onset ptosis, sudden onset proptosis, sudden onset ophthalmoplegia, sudden onset loss of vision will have score 1 each. Now, this has already been told to us by Dr. Vidya Rokde. These are you can see the hyphae. The important thing is that they are 90 degrees to each other. That is the diagnostic criteria for KOH mounting. This is where in short, the anatomy, why ophthalmic structures goes on involvement of the various nerve, because superior orbital fissure and inferior orbital fissure has got important structures that directly come from the brain and enter into the orbit. What is important is whether we should do a CT or whether we should do a MRI. Ideally speaking, for early diagnosis, it is necessary that gadolinium imaging MRI is very useful in early tissue diagnostic, even before involvement of the, or even before the patient becomes symptomatic. Now, in management, what is important is probable rhino-orbital cerebral mucormycosis. You do RT-PCR. If the RT-PCR is positive, you admit the patient. If the RT-PCR is negative, you admit the patient in the non-COVID ward. What is the treatment protocol? Possible proven rhino-orbital cerebral mucormycosis is urgent surgical debridement and strict hypoglycemia control of sugar levels is very important. As it has been already told regarding the dose of the amphotericin B, always make sure that when you are giving amphotericin B, ideally it should be done, given in the hospital setup, because it needs a test dose. And second thing is pre-hydration is required and second thing is post-hydration is required. You have to watch for various parameters. Therefore, amphotericin B should not be administered during on OPD basis to the patients. Important thing regarding renal function is you have to keep a strict watch on creatinine levels. If the creatinine is less than 1.1, you can use amphotericin B, which is lipolyzed. If it is non-lipolyzed is available, you should not use it if the serum creatinine is on higher side. Along with amphotericin B, we are starting posaconazole tablets oral for at least 4 to 6 weeks. There are now so many patients are there on tablet posaconazole, even though it is short. What is important clinically that blood posaconazole level has to be monitored when you are giving posaconazole for more than 1 week therapy. And chemogram should be done to find out the neutropenia in these patients. If the patient is on amphotericin B, there are certain types of chart that you are supposed to maintain, with the starting time, ending time, the dose, whether the cumulative dose, urea level, creatinine level, serum electrolytes, or any complications patient has developed. Surgical management, early surgical treatment is always beneficial, especially ENT management, that is the frequent debridement of the infected tissue is needed for early recovery of the patients. Therefore, the ICMR suggests the endoscopy has to be done after every 72 hours in all the patients, whether the patient is admitted or not. Therefore, you should not say that the patient is asymptomatic, you don't have anything, you can leave now. The thing is that you have to do endoscopy and ophthalmic examination to find out the mucormycosis every 72 hours. Depending upon the surgical management, whether the nasal or sinus involvement, endoscopic sinus surgery. If there is a maxillary involvement, partial or total maxillectomy has to be done. If there is a maxilla zygoma involvement, there is maxillectomy, total or partial with zygoma debridement. If there is a zygoma maxilla plus orbit, the maxillectomy, debridement of the orbital floor has to be done. If it is a patient has got a vision loss or ophthalmoplegia or a necrosis of the orbital tissue, we have to do exenteration in all these patients. But recently there has been this is a patient which has taken for exenteration. This is how it looks after we remove everything. This is a lid sparing exenteration that we have done, where the leads has been spared and the whole of the contents of the orbit, including the periosum, has been removed. What is another important thing? What is the follow-up of surgery? Okay, repeated examination of nasal cavity is very necessary. This is regarding the surgical removal of the total contents of the eyeball, where there will be a diffuse orbital involvement, whether there is a unilateral, no useful vision, or medium or cavernous. If the infection is progressing towards cavernous sinus, we have to do exenterations. Now, every one of us are using steroids quite profusely during the time of COVID, because it is the only drug that has been shown very much good response for saving the life of the patients in COVID. This is the suggested doses we should not exceed while when we are giving steroids to the patient. Dexamethasone 6 milligrams daily for 7 to 10 days. We should not exceed dexamethasone injection for more than 7 to 10 days. If you are giving hydrocortisone 50 milligrams, it should be given every 8 hourly for not more than 7 to 10 days. If you are using methylprednisolone, you have to give methylprednisolone 10 milligram every 6 hourly has to be given. Now, what is important for us is we should know what is the preventive measures that has to be taken for prevent the mucormycosis. One is good oral hygiene. Second is judicial use of steroids. Very strict control of diabetes. Okay. Use of proper sterile equipments and everything for patient when you want to see the post-COVID patients. This is the latest thing that has been come that we are doing, that if we are suspecting the orbital involvement of the because of mucormycosis, we are giving retrobulbar injection of amphotericin B, where we can save the can save the sight of the patient, or we can save the patient's patient for undergoing exenteration. We are giving retrobulbar amphotericin B at the dose of 1 milligram per 3.5 milligram per ml. It has to be given for 3 to 5 doses. First dose is given, then the second dose is given on the third day, fourth dose, then the next dose is given on fifth day, and another dose is given on day fifth. We have found very good response after giving the amphotericin B in the retrobulbar cavity. This has definitely helped us to prevent the spread of amphotericin B into the brain. And this is how the patient looks after exenteration. And this is quite traumatizing to the patient, not only traumatizing to the patient, and it is for the society. It always forms a social stigma. These are the prosthetic glasses that we use in these patients. I will thank Mucormycosis Task Force, and I will thank All India Ophthalmological Association And thanks a lot. I will thank Dr. Prasad Sonis for giving me my short introduction. Thank you and good night, everybody. I will ask Dr. Prasad to take over.
Yes, thank you very much, sir. It was really a extensive but very informative talk. There are few questions. I think if the president is permitting, then we can go for the question answer session. It's 11 o'clock. So,
Yes, sir. For 5 minutes more, we can answer the question.
okay. So, my first question to Ramesh Bhange sir, that what if you said that the MRI is the gold standard to diagnose the early cases of mucormycosis,
Hmm.
but what if in many times the MRI is contraindicated in many situations? Then does the city do the same quality work that
No.
time?
If
Then
you
what-
want to do an early diagnosis when the patient is asymptomatic and you are suspecting that the patient is likely to have mucormycosis, the only thing that MRI helps in early diagnosis is the picture of the MRI where we see the hypodense or the ischemic areas of the tissue, which is the earliest indication of involvement because of mucormycosis, which is not possible with CT scan.
Okay, then what if the patient there are some artifacts in the MRI, or if the patient had undergone some hip replacement surgeries and this, that time the MRI is contraindicated. Then what? Being a primary physician, what we should do?
See, in those cases, you can do CT scan. The thing is that if the patient has contraindications for MRI or other things, only thing you can repair, the most important thing is that instead of rushing for the diagnostic tools, you can directly start with, depending upon the hematological investigation, you can directly start with antifungals in these patients. Both injection amphotericin B and posaconazole should be started as early as possible to save the life. You should not wait every time that you will get all the reports and everything in time, because we start once the patient is early symptomatic, we immediately start the amphotericin B and posaconazole. We will not wait for the patient's report to come that we'll see the CT or we'll see the MRI and then we'll see. We'll just do the blood counts. We'll look for the neutropenia. We do the nasal endoscopy. We do oral cavity examination, and we'll start antifungals in these patients after doing blood investigations. We'll not wait for all the rest of the, whether if there are so many patients those who have been treated at primary health center where the patients, these diagnostic facilities are not available. That is the reason why government has made now amphotericin B available even at the primary health centers, where this we are sitting in the institute and then we are controlling the things. The thing is that when you see the patient as primary health center level, we will not even wait for the patient to refer to the higher center. We will say, start with amphotericin B, start with posaconazole, and refer the patient. We will not wait for anything.
Thank you, sir. My next question is for Dr. Vidya Rokde, madam. Madam, what is the general incubation period for the mucormycosis after COVID infection? Means after how many days we should suspect the patient may be having mucormycosis? 15 days, 20 days, 1 month, 2 months?
Initially, we have seen the cases, most of them after 7 days, 7 to 10 days. But now we have seen it even after 5th day. Even those they are in the ICU, RT-PCR positive patients, they are also showing now the symptoms and signs of the mucormycosis. The initial cases were definitely, they were discharged, they went home, and then they started coming back with the facial swelling, numbness, and the lid edema.
Okay.
So we can say it is a 5 days to 7 days in the post-COVID infection.
Thank you, ma'am. A question for Dr. Ramesh Bhange, sir. Sir, you said that the congestion of the eye is a very common symptom that you see, the initial symptom that you see in mucormycosis. Then congestion of eye is seen in many conditions of the eye. Then in family physician's perspective, do we need to see any typical pattern of the congestion? Like conjunctivitis, it is different. Scleritis and this thing, it is different. So in COVID mucormycosis, does this pattern is different from the other patterns?
To speak you truly, the COVID virus doesn't appear in tears. That is the important thing. Second important thing is that whatever we see as a congestion, we are trying to differentiate between the congestion and conjunctivitis. When we see congestion, there is a involvement of the deeper tissue. If we do just put a ice pack on the patient's eye, and if the congestion disappears, that means it is superficial. If the congestion doesn't disappear after putting the ice pack, that means the deeper tissue is involved. And another very important thing is that not to start steroid eye drops in this patient. That is very, very important. And not to start even antifungals. Another important thing that I have forgotten to tell that voriconazole, Zocon, or the fluconazole are not effective in these patients. Therefore, please do not start these drugs. These drugs are contraindicated in mucormycosis patient because it happened that we have found the patients that not only mucormycosis, other fungal opportunistic infections are found along with mucormycosis. Therefore, we are speaking of just mucormycosis. That doesn't mean that the patient is purely of mucormycosis. The just congestion is not. If there is a congestion, don't start steroids. Do the eyes test. If you find that the congestion disappears, don't do anything. Don't even give plain antibiotic drops. If the congestion persists, if there is a limitation of movement, see the pupillary reaction. If the pupillary reaction is changing, you see the color vision, you can ask the patient to look at his mobiles and everything. If there is a difference in the appreciation of colors, that indicates that the orbital involvement is there. That is the involvement of the optic nerve. That in the OPD, you are supposed to look at the pupillary reaction in both eyes, both direct and both consensual. You are supposed to look at the color vision in each eye.
Thank you, sir. My next question is for Rokde madam. Madam, you said that in posaconazole, a tablet is preferred to the oral suspension. Why it is?
Because it's a sustained release.
Sorry.
So that's why it is preferred.
We haven't. What you said, man?
Sustained release. Slow releasing.
Slow releasing.
So that's why the tablet will be preferred over the suspension.
Oh, it is slow releasing. Sustained. Okay. Thank you, ma'am. And one more question to you. In your slides, you said that the oxygen is a precipitating factor. So how could oxygenation could be a precipitating factor? Is there any use of dry oxygen and the moist oxygen which is responsible for the mucormycosis in patient? Is it like that, or is there any theory like that?
I think I said it was clearly mentioned it's a hypoxic status. So low oxygen level.
Low oxygen level.
Low oxygen level. So that is a good medium for the fungus to grow in.
Achha.
So it is a low oxygen level.
We can use any form of oxygenation, means moist or dry, both are good, means they are not in any way precipitating or helping mucormycosis?
That was in vitro, means in a individual body. What we're that slide was pertaining to that, and what we're talking about, the oxygenation, giving the oxygen to the patient. So these are the two different things.
Okay.
There was a little bit probably some confusion that what I'm talking about, the good cultural environment. So why they grow more faster in these mucor patients, post-COVID patients. So this is a good environment for the fungus to grow in.
Okay.
So hypoxic status, that is a low oxygen level, is a good culture and a good medium for them to grow in.
Okay. So most of the patients in the ICU setups, they are getting the humidified oxygen, and because of that, means you said the hypoxic medium is good to grow the mucormycosis.
Because
But
it starts there, yeah, and
humidified-
then humidified oxygen. But there now there are we are coming up with the things that probably what we use for the humidified oxygen is tap water. So rather than using the tap water, because it is a medium for a fungus spore to travel in. So now we have changed the practice. So there are guidelines not to use the tap water for the humidification of the oxygen. Rather than that, use a sterile water. So that precaution is now taken. So to prevent. So all these are the theoretical things that we are thinking thinking on the terms to minimize the risk factors. So one of that risk factor.
it's not oxygen, it's a tap water which is responsible for
Yes, so it is not oxygen, it is a tap water which is responsible.
Thank you, ma'am. One more question to you. Does the X-ray PNS is helpful in diagnosis of mucor in any way? Means right from the beginning to anywhere. X-ray PNS.
X-ray PNS, because if it's a radiological investigations, X-ray PNS as such is not at all diagnostic, going to help us. Only thing is that X-ray PNS will give us an sinus thickening, haziness is there or not, of the sinus is there or not, like any sinusitis. It will not give us an exact idea whether it is what kind of a pathology we are looking into it. If at all it is involving the sinuses. So that sinus involvement will come to know whether, because even in the sinusitis, the mucosal thickening will show as a haziness in the paranasal sinuses. So that with the mucormycosis also, it will show the haziness, but it will not differentiate whether it is a fungal infection or not. For that, MRI is the only option that will give us an exact idea. And if there is at all bony destruction with the limitations of the X-ray, we'll able to see any bony destruction there.
Madam, last question.
I hope that.
Madam, thank you, ma'am. Madam, last question to all the speakers, all three of you, that we are already seeing a lot of diabetic cases, uncontrolled diabetic cases, onco cases, and HIV or AIDS cases. We were examining and treating these cases for many years now, but we haven't seen many mucormycosis cases. What had happened after COVID? And you are relating mucormycosis with the COVID. So what had happened after COVID that the mucormycosis cases has jumped up? So all these disease conditions, the immunity is very low. So that time the mucor was not coming up. Mucormycosis, we haven't seen the mucormycosis case at that time. Then why in these 2 months or 3 months we are seeing so much of mucormycosis cases?
Can I answer this?
Yes, sir. Please go on.
Yeah. Recently, there are a lot of postulations has been made why mucormycosis has suddenly showed a breakup in this pandemic area. COVID-19 affects all the systems in the body. It affects brain, it affects nasal cavity, it affects chest, it affects all blood vessels, it affects pancreas, it affects all the organs in the body. As the virus is changing its mutation, when it when it started affecting the pancreas, suddenly there is a increase in patients of those who are pre-diabetic have turned into diabetic after the COVID-19. This is just a postulation that has been recently came up, that because of this increase in sugar level plus increase in ferritin level, basically all COVID-19 mutations, all mutation strains are causing vasculitis, and decrease because of vasculitis. There is a lot of destructions of the RBCs, and the serum ferritin levels are increasing. And because of increasing serum ferritin level with diabetes and increased blood sugar levels leads to is a very good environment for fungus to grow. Recently, they have said in the All India meeting that whatever the postulation has been made regarding the use of humidifier, oxygen, and these things, the important thing is that the oxygenation per se, whether you use it humidifier or whether you use it dehumidifier oxygen, what it causes is causes the destruction of the normal nasal mucosa. And because of destruction of the normal nasal mucosa, what happens is that it becomes very vulnerable for trauma. And because of trauma, uh, every time patient goes on touching his tissues which are rather decrease immunity. It is, you might say the nasal mucosa, you might say the oral cavity, where the patients are likely to touch every time. And because of hypoxia, because of hyposthesia, and as the mucormycosis is present all over in the our environment, this fungus gets entry into the body. It is a opportunistic infection, and it doesn't enter into body without invasion. It is not inhaled. It has to be uh, inoculated into the body. Then only the mucormycosis spreads. If you take the history, because this has come recently in the webinar, they said it is nothing to do with it. It is a tissue invasion that occurs accidentally that leads to mucormycosis.
Okay. Ropna madam, over to you. Anything you want to add?
I think he has covered almost everything. So,
Okay.
yeah.
Okay. Thank you very much, all the speakers, and thank you very much for your valuable time for PSRDA. And with this, I will hand over the session to the secretary, Dr. Vidyalata Joshi ma'am.
Thank you, Prasad Soni sir. Thank you, Dr. Vidya Rokde madam. Thank you, Dr. Ramesh Bhange sir. And thank you, Dr. Yashovardhan Bhange sir, for this very important and useful lecture. The lecture was well elaborated and guided by all of us. We would like to attend more lectures. We all want to thank you for this lecture. Thank you all the team, a convener, Dr. Prasad Soni sir, and thank you Mr. Piyush from Digital team for technical support. Thank you very much. Sir, you want to speak?
I just wanted to add one thing. Everyone is thinking that the second wave of COVID is over. It is not over, because we are likely to face many complications of secondary infections like mucormycosis. Maybe something new will come up in third wave. It is may not be the third wave. As the COVID virus will go on changing its mutation, new things will appear. Therefore, it will be wrong on the part of us to think that the second wave is gone. We are still have to face the sequelae of second wave. That is very important. And we, as per the data goes, we have seen the mucormycosis infection even after patients taking having COVID, taken 2 doses of vaccine, still the patient had mucormycosis. Therefore, we should not think that COVID is over. COVID is still there. Only thing is that don't be under wrong impression that because we have done vaccination, patient had a single attack of COVID. We have seen patients where patients are there with a second attack of COVID, and they have died in second attack of COVID. We still yet to found the cause of why patients died in after both the things, because we are not doing the postmortems in all these patients. Apart from comorbidity, it is very difficult to root the cause why patients are dying in these things. That was the only thing that I wanted to add. That was the reason I interrupted. Thank you, everyone.
Yes, sir. It's very nice information, sir.
Thank you.
Thank you.
Thank you very much. Thank you very much, all.
Ma'am, I'll close the webinar.
Yes, yes, yes.
All right.